Hello, everyone. Thanks to everyone who's joined us for our Assessing Culturally Appropriate Treatment in Communities of Color, the Role of Providers to Improve Quality of Care for Opioid Use Disorder webinar this afternoon, or this morning, depending on where you are. My name is Juliet with the HHS Office of Minority Health, and I'm pleased to be your moderator for today's webinar. Next slide, please. So before we begin, I'd like to go over a few housekeeping items. First, this webinar is being recorded, and you'll receive an email after the webinar, which will include a link for the recording. All participants will be automatically muted throughout the duration of this webinar, but we will have time for questions after our last presentation. So please feel free to submit your questions at any point during the webinar via the chat box. And we'll try to answer as many questions as possible. We're trying out a new format today where we're providing brief presentations and hopefully allowing for more time for Q&A, so please send those questions in. And then finally, you can download the slides from the handout section in the navigation panel. Next slide, please. So we're offering Certified Health Education Specialist credits and 1 CME credit through Meharry Medical College for this webinar. If you're interested in receiving CME credits for participation in this webinar, please download and complete the CME evaluation form and email it to minorityhealth@hhs.gov no later than Tuesday, February 4th. And that form is also available in the handout section of the navigation panel. If you downloaded the form yesterday, just a note that you should download it again because there was a minor update to the form. Next slide, please. I'd like to give a big thank you to Mildred Hunter, Marlene Vignier, and Danny Gallardo for their coordination of today's webinar. Next slide, please. So today we're excited to have presentations from experts focused on culturally and linguistically appropriate opioid use disorder treatment. So welcome and thank you to Captain Felicia Collins, Dr. Michelle Peavy, Ms. Celena McCray, and Dr. Pierluigi Mancini. Next slide, please. So today we'll provide an overview of the national CLAS standards, discuss why and how you can provide culturally and linguistically appropriate services, and learn about some resources to support these efforts. And before we begin our presentations, I want to provide some additional context for this webinar, which is part of a series through which we at OMH want to elevate a call to action for providers to address opioid-related disparities experienced by racial and ethnic minority populations. Our first webinar focused on a call to action for providers to engage in prevention. Our second webinar focused on how providers can help break down barriers to treatment. And in today's webinar, we asked providers to ensure services are culturally and linguistically appropriate. And we hope you will feel empowered to respond to this call to action. Next slide, please. It's my pleasure and my honor to introduce Captain Felicia Collins. Captain Collins is Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health here at the U.S. Department of Health and Human Services. Captain Collins has also served at the Health Resources and Services Administration and the Food and Drug Administration at HHS and is a pediatrician. Captain Collins.
Next slide, please. Thank you and good afternoon. Good morning to those of you on the West Coast. It really is a pleasure to welcome you to the final webinar of our series on the opioid crisis and racial and ethnic minority populations. Now, before we launch into today's planned presentations and discussions, I want to provide a brief overview of the HHS Office of Minority Health, or OMH as we call it, as a reminder to those of you who've joined us on past webinars, and as an introduction in case there are those of you who might not be familiar with OMH. Our mission is to improve the health of racial and ethnic minorities and American Indian and Alaska Native populations. And we do this through developing programs, policies, and practices that result in the elimination of health disparities for the communities that we serve. Now, if you look at the chart on the right, this shows the primary functions of the office. And I always like to say that I like to start with that red slice of the pie, which represents our efforts to promote policy, program, and practice adoption. Because once we identify what specific policy, program, or practice we are trying to promote, then it helps to guide our convening of partners, our collection and analysis of data, our dissemination of information, and our conduct of demonstration and evaluations. Because we do have some time-limited programs and dollars to actually test out new policies, programs, or practices. And when the policies, programs, or practices are identified successful, whether we've actually studied them or whether we've become aware of them from other venues, we seek to find homes with them from our partners within the government and within communities so that they can be sustained and spread. Our office also works to promote cultural and linguistic competence across all functions of the office, and that's the CLAS, or CLAS, that you see in purple in the middle of the pie graph. And you'll hear more about cultural competence and the national CLAS standards in my subsequent slides and from our other presenters today. Next slide, please. Now, if you were able to join us for the first webinar of the series, you heard why the opioid crisis is so critical to address in communities of color. While we know that the impact of the epidemic affects every community, racial and ethnic minority populations and American Indians and Alaska Natives bear a disproportionate burden of the epidemic. Providing effective and quality prevention, treatment, and recovery services are critical to helping individuals, families, and friends affected by opioid misuse and addiction. And the presenters for today's webinar are going to share why the provision of culturally and linguistically appropriate services is so important for combating the opioid epidemic in the communities that they serve. Culturally and linguistically appropriate services refer to services that are respectful of and responsive to individual cultural health beliefs and practices, preferred languages, health literacy levels, and communication needs. And providing healthcare services in this manner is increasingly becoming recognized as effective in improving the quality of care and services. When discussing cultural competence, I also like to include the term implicit bias. And implicit bias refers to the attitudes or stereotypes that affect our understanding, our actions, and our decisions in an unconscious manner. Now, these biases, which can encompass both favorable and unfavorable assessments, are activated involuntarily and without our awareness or intentional control. So in my mind, the question is not whether we have unconscious biases, because I do and you do and we all have these unconscious biases. The challenge results when we base our actions and decisions in the healthcare arena or any other arena, when we base our decisions on these unconscious attitudes or stereotypes. And the good news is that working on our cultural competency is a great way of becoming conscious of those biases so we can consider if or how we should adjust our actions and decisions. By providing culturally and linguistically appropriate services, health and human services professionals can build rapport and a trusting relationship with individuals so that they can better understand and address the needs of individuals. This in turn can improve adherence to treatment, increase individual satisfaction with services provided, and support better health outcomes and healthcare overall. Next slide, please. Now, there actually are national standards for culturally and linguistically appropriate services, known as CLAS or CLAS standards. And these were first developed by the Office of Minority Health in 2000. The CLAS standards provide a set of 15 action steps for providing culturally and linguistically appropriate services that support optimal health and health outcomes for our nation's diverse communities. And these national standards were actually enhanced in 2013. But you may be asking yourself, why should I care as a provider about the implementation of these national standards in health and healthcare settings? And I'd like to share some reasons why. Number one, we all know that we've seen a rapid change in demographic trends in the United States in the last decade, and the nation is growing increasingly more diverse. So it is increasingly likely that providers like myself and like you on the call will be working to support good health in partnership with patients from different backgrounds. Number two, we all know that health disparities have adverse effects, not only on the individual and the local level, but nationally as well. Now, this was a statistic that was new to me, but listen to this. The combined cost of health disparities and subsequent deaths due to inadequate or inequitable care is estimated at $1.24 trillion, and that's a T for trillion. In addition to the economic benefits, and more important in my mind, CLAS is also effective in improving the quality of care and services and supporting patient adherence and addressing access barriers. Of note, national and state level healthcare policies and legislation also have underscored the importance of cultural and linguistic competency as vital to providing quality healthcare and services. States including Washington, Texas, Illinois, New Jersey, and Florida have all passed legislation regarding educating health providers on cultural competency. In addition, there are accrediting bodies such as the National Committee on Quality Assurance, NCQA, the Liaison Committee on Medical Education, and the Accreditation Council for Graduate Medical Education have all embraced cultural and linguistic competency as a way to improve care and reduce health disparities. Next slide, please. So if you were not already convinced, I hope I've convinced you why culturally and linguistically appropriate services are appropriate in healthcare overall, and in particular as we work to address the opioid epidemic. So, but what do you do next? And I'm glad that you asked. I invite each of you to visit the Office of Minority Health Think Cultural Health website for resources to help you learn more about CLAS, the national CLAS standards, and how to implement them. Our Think Cultural Health website, or on this website, you'll find a number of free learning programs designed to help you learn more about how to provide culturally and linguistically appropriate services. And there's the added bonus that as you are learning, you can also receive continuing education credits. In particular, if you haven't already, I strongly urge you to review and share with your networks the Think Cultural e-learning program for behavioral health providers, which is accredited for licensed alcohol and drug counselors, nurses, psychologists, psychiatrists, and social workers. Next slide. And so after you complete the Think Cultural training, then what? Again, I'm glad you asked the question. I'm also especially excited to invite each of you to join our new learning community that OMH is hosting in partnership with SAMHSA's Office of Behavioral Health Equity. This is a forum for you to engage with others across the nation, to continue the discussion and information sharing, to build on opioid and related issues that you've covered in this webinar series and beyond. To join, you simply email connect@nned.net with the subject line, Interest in Opioid Learning Community. In the email, be sure to include your full name and the email address you would like to use for the learning community membership. You'll get an email with instructions on joining the NED, as it is affectionately called, after assessing the learning community. And you'll also receive a follow-up email after this webinar with more information about the learning community and information on how you can join and participate if you didn't get it all down from this slide. Next slide, please. In closing, I want to emphasize the fact that whether you're a physician, a nurse, a counselor, a peer support specialist, a social worker, or another type of provider, or if you are interested in the opioid epidemic for another reason and are also joining us today, you can play an important role in addressing the impact of the opioid crisis in communities of color. My call to action for each of us is that we will apply the strategies, approaches, and tools that we will hear about today and have heard in this series overall, and that we'll use these tools to help racial and ethnic minority and American Indian and Alaska Native individuals and communities in need of help battle this crisis. Now, if you missed our past webinars or need a refresher, recordings are available on the Office of Minority Health YouTube page. And I also encourage you to share your thoughts for action and your resources to keep us moving forward in the evaluation survey that you will receive. Once again, I thank you for all that you've done, all that you are doing in the future to help us work together to fight the opioid epidemic. Thank you.
Thank you so much, Captain Collins. Our next speaker, Dr. Michelle Peavy, will share more about the importance of cultural humility in treating patients of color with opioid use disorder. Dr. Peavy is a licensed clinical psychologist with clinical and research expertise in substance use disorder treatment. Currently, she serves as a consultant at Evergreen Treatment Services, an opioid treatment program in Seattle, Washington. Dr. Peavy obtained doctoral training at the University of Montana, after which she was a postdoctoral fellow at the Center of Excellence in Substance Abuse Treatment and Education at the VA Puget Sound Healthcare System. Welcome, Dr. Peavy.
Thank you so much, and thank you so much for inviting me to speak on this very important topic. So I want to acknowledge that I am speaking to you from the traditional land of the Duwamish and Coast Salish people. So I come to you today as an expert in opioid treatment with 20 years of experience working clinically and in the research realm in this area. But before I go any farther, I just want to point out an experience gap on my part as it relates to this webinar, which is I do not have the experience of being a person of color or having a minority status. So given this colossal experience gap, how do I, a white person of privilege, go about working effectively with patients and clients of color? Next slide, please. So adopting a stance of cultural humility is a really good start. So cultural humility is a way of being with clients and patients of color. And that way of being involves openness and a genuine humility. It means we walk side by side with our patients and clients. We shed our expert roles and we assume that the people in our offices are the experts on themselves and their experiences, especially in relation to aspects of that person's cultural identity. So I want to let you know that adopting a stance of cultural humility is evidence-based. That is, cultural humility is related to improved therapeutic alliance, and it is also related to positive treatment outcomes, and that these relationships are actually demonstrated empirically. So what does that mean, and what do we take away from those findings? It may mean that as providers, if we can demonstrate cultural humility, we have the opportunity to improve our relationship with clients as well as their treatment outcomes. Next slide, please. So what does it look like to practice cultural humility? It means adopting a beginner's mind. So it means we don't have any preconceived ideas about what it might be like to inhabit the bodies and beings of our clients and patients of color. Instead, with the beginner's mind, we might allow that person to tell his, her, or their own story. So cultural humility means that we broach issues around culture, race, and ethnicity. So for example, if I'm sitting with a minority patient or client, I might have the thought that I don't feel like bringing up the topic of cultural identity, or maybe I feel awkward about talking about race, or that I won't word something correctly, or I may simply feel uncomfortable. But adopting a stance of cultural humility means that I broach the topic anyway. It means that I ask. And finally, cultural humility means that we recognize our limitations. What Dr. Collins said about implicit bias applies here, and we put our own limitations right out there on the table, and we empower the patients in front of us to fill in those gaps. Next slide, please. So I just spent some time talking about how we can approach an individual patient or client with cultural humility, and now I want to pivot to healthcare and treatment settings and how they can adopt policies that will enhance retention in opioid treatment. So first, let me just say we have highly effective treatment for opioid use disorder. We have not one, not two, but 3 efficacious medications that successfully target opioid use disorder. So the problem is not that we don't have successful treatments that work. We do have successful treatments that work. The problem is that people are not accessing those treatments or they are not staying in treatment. So this issue of retention differentially affects people of color. We know that individuals of color are less likely than white patients to stay in medication treatment for opioid use disorder. So I'll argue that in order to affect health disparities in opioid treatment, we really have to address the retention in healthcare and treatment settings in terms of medication treatment for opioid use disorder. So how do we get people to come to and stay in treatment? I'll emphasize the staying in treatment part. So one way we can get people to stay in treatment, medication treatment for opioid use disorder, is if we don't kick them out. So this may mean keeping people in medication treatment even if they are continuing to use substances. It may mean keeping people in treatment even if they chronically miss their appointments with you. But let's remember that if we can keep people in medication treatment for opioid use disorder, they are more likely to live than if they are not in treatment. And remember that race matters when it comes to retention. So if we can change our policies to enhance retention, maybe we can chip away at this disparity. Okay, next slide, please. And this next slide is simply a summary of what I just said, which was nice and quick because we're going to save time for questions. And on my next slide is the list of references. And I just want to thank you all in the audience so much for your interest in treating individuals with an opioid use disorder. And thank you to the organizer. And this concludes my part, and I'm very excited to hear from our other panelists. Thanks so much.
Thank you, Dr. Peavy. Our next speaker, Ms. Celena McCray, will share about the importance of understanding the tribal perspective and culture in treating substance use disorder. Next slide.
Thank you.
Ms. McCray is a tribal member of the Navajo Nation and serves as a Thrive and Washington Department of Health Parenting Teens Project Coordinator at the Northwest Tribal Epidemiology Center with the Northwest Portland Area Indian Health Board. Her clans are the Bitterwater people born for the Mountain Cove people. She provides suicide prevention training, technical assistance, and develops culturally appropriate media campaigns and resources related to suicide prevention. Thanks for joining us, Ms. McCray.
Yes, thank you. I want to thank everybody joining me today and also the panelists and then everybody who has organized this amazing webinar. I'm excited to share some of the awesome things that we have in store. So next slide, please. So from tribal people on Turtle Island, current and past political and social events have helped shape the context of our lives in the ways that many other Americans do not experience. The study of trauma, historical and present, has connected historical genocide, assimilation, oppression, and disparate treatment to such symptoms as depression, suicidal thoughts, anger, anxiety, low esteem, and difficulty in both recognizing and expressing emotions and impact of substance misuse. So therefore, a culturally responsive public and mental health system must recognize the broader social and political factors that underlie mental health issues for communities of color. Next slide, please. Substance use disorders can impact anyone because it is a chronic health condition and not a moral failing. As a community, tribal people can look towards the story of the trickster, or what we call the tricky one, to learn how substance use disorders can impact Native communities in similar and sneaky and cunning ways. In oral tradition, trickster is a sacred being that assumes many forces. Trickster scandalizes, disguises, amuses, disrupts, and humiliates, yet he's also a creative force in transforming the world with his instinct energies and cunning. He represents both the most basic instinct, but in other narratives, he is also the father of the native people and a strong conductor of spiritual forces in the form of sacred dreams. The trickster helps us understand our culture's original instructions. So therefore, in respects to substance use disorders, the substances we use are first medicines meant to cure, heal, and alleviate pain. All tribes traditionally use pain relievers to heal the people. At some point, this medicine transforms into misuse of the medicine and then moves into dependency. It gets twisted up and transforms into something different, into what we call addiction. We can imagine that there is a trickster spirit that is in this, a spirit that is attempting to reach us and teach us important lessons, which is lessons of humility, compassion, or living in balance in the natural world. Respect for the spirit and medicine we use is such a unique way. The use of the word medicine is not in the Western context of prescription, but rather the energy of spirit that traditional medicines carry. Next slide, please. In order to heal and learn the lesson that trickster has to offer, we need to address our relationships to medicine rather than substance use disorder processes by shifting our understanding and relationship with medicine. The current perception of substance use disorders stigmatizes and produces shame or guilt. And therefore, other methods such as medication and counseling treatments are also ways we need to utilize. Our Northwest Portland Area Indian Health Board has created certain documents that highlights these ideas and resources you can find at our website at npihb.org. If trauma impacts the epigenetic transfer of trauma, culture and connection can mitigate these effects. Next slide, please. So I definitely want to thank you all for having me and everybody to join us. I also have in our next slide additional resources related to the ACE scores and including some other useful information on historical trauma to help you understand additional information on that. So thank you so much, and I'd like to hear from other presenters as well.
Next slide, please. And the next slide. Thank you so much, Ms. McCray. So our final speaker today is Dr. Pierluigi Mancini, who will share about his efforts supporting opioid treatment programs and the implementation of the national CLAS standards. With over 30 years of experience in culturally and linguistically appropriate behavioral health treatment and prevention, Dr. Mancini is one of the most sought after national and international consultants and speakers on the subject of mental health and addiction. And his areas of expertise are immigrant behavioral health and health disparities. Dr. Mancini, thanks for joining us.
Hello, everyone. It's a pleasure to be here with you today. I wanted to share with you some of the findings of a help I've been giving a few opioid use disorder organizations while they learn about and implement the enhanced national CLAS standards. Next slide. The project involves a process of helping organizations providing different levels of opioid-related treatment and recovery support services. How do we implement the CLAS standards? I would like to share the approach I'm taking in helping these organizations learn about where they are in the cultural and linguistic competence continuum and how to move forward towards implementing the CLAS standards in their organizations. These organizations vary in size, from having less than 10 employees to having hundreds of employees. Next slide. The following organizational barriers were reported by some of the participants: lack of understanding, lack of resources, lack of leadership commitment, training opportunities, and staff resistance. The organization must be aware of these organizational barriers and be prepared to address them. Pushback is often expected, but as long as the implementation becomes part of the strategy and is supported by the highest levels of management, it can move forward. Next slide. One specific barrier that was identified was the discrepancy between the human resource makeup of the organization when compared to the individuals they serve. On average, 63% of the governance, administrative, and service staff of the organizations were white, while only 36% of the population they served were white. Having your workforce represent the individuals you serve is extremely important when trying to serve minorities. It not only empowers your workforce, but the individuals you serve. Many of these organizations were struggling with attracting minorities into their program, and they often wondered why people were not coming in. Next slide. The review of the assessment tool used provided enough information to place each organization in one of a 4-point scale to measure the spectrum of competency that organization currently holds. The preliminary results placed 4% of them at stage 0, or the pre-stage, 13% at stage 1, 44% at stage 2, 26% at stage 3, and 13% at stage 4. What this means is that 87% of these providers are not equipped to properly serve someone with cultural and linguistic access barriers. Next slide. For these providers, the next step was to develop an implementation framework using the 6 areas for action from the CLAS standards. Some of the steps for fostering cultural competence include, for example, identifying committed champions of cultural competency within the organization and allocating organizational resources to educating senior leadership, staff, and volunteers. Getting the buy-in from leadership is one of the key foundations to making sure that this can happen. Steps for reflecting and respecting diversity included implement recruitment, retention, and promotion policies for a workforce that reflects the diversity of the community being served, but also establishing formal and informal methods to obtain and process feedback from patients and staff. Steps to ensure language access include develop a communication and language assistance plans and providing training for the staff on language services and even interpreting services if necessary. Steps for building community partnerships included partnering with community organizations and employing community health workers or promotores de salud. And steps for collecting diversity data included collaborating with community in data collection, but also analysis, reviewing, and reporting, which is often missed. And then, of course, conducting a community needs assessment. And finally, the steps to benchmark, plan, and evaluate include identifying the champions, appointing a cultural competence committee, and making sure that this process is integrated in the strategic plan of the organization. Next slide. It was also important to share with the organizations why it would be beneficial for them to implement these CLAS standards. Things like the social benefits of increasing trust between the individual being served and the organization. Health benefits included reducing the numbers of missed sessions. Business benefits included increasing market share for the organization, and legal benefits included improving risk management, which includes the risk of liability. Next slide. Thank you so much for the time you've given me, and I look forward to questions from you.
Thank you so much, Dr. Mancini. Next slide, please. So a hearty thank you again to all of our presenters for taking the time to share their expertise with us today. So now we'd like to take the rest of the time in this webinar to tackle questions from our audience. And we've had several come in already that we'll address, and I invite participants to continue to submit your questions via the chat box in the navigation panel. So I'd like to pose our first question to Ms. McCray. You mentioned the role of trauma for tribal populations as it relates to substance misuse. How can culture be utilized to address trauma and to support treatment and recovery?
Yes, thank you. That's a really great question. In terms of culture as prevention, that's something that we have been utilizing for so many generations at this point. You know, with the whole, aspect of the trauma that was done, we've continued to, I think at this point right now, with this generation is starting to revitalize some of that information. You know, some of the things that I mentioned through the presentation about using the trickster story is a way of helping us get back into those connections. And it's really from those oral traditions and stories that help us revitalize some of that information. Because without culture, we're unable to really dig down into deep of what we've known carrying from our ancestors prior to assimilation. And I also believe that with treatment and how we're able to address those areas, that could really help us to identify some things that we never may have mentioned or seen before in our lives. And I think as we continue to help each other culturally and also as a community, people will understand some of those aspects. And I really appreciate that this panel is speaking about ways of how providers and understanding culture, humility, understanding their positionality as well too, to approach those in those ways. So being able to be culturally sensitive and understanding those approaches can really leverage some of those ideas and being able to treat as much as possible.
Thank you, Ms. McCray. Our next question is for Dr. Peavy. So Dr. Peavy, could you go into more detail about how race matters in treatment retention? And then how do you get buy-in at your organization? For example, how would you introduce the concept of cultural humility and training in organizations where this is not seen as an issue?
Oh, that is such a good question. So first, how race matters in terms of retention. We know that individuals of color are less likely to be retained and maintain treatment. The research that I looked at was specifically looking at medication treatment for opioid use disorder. So primarily in opioid treatment programs like the one I work at, where we have methadone and buprenorphine. So because retention overall is a problem, but ethnic minority and individuals of color are more likely to drop out or not be retained, we need to bring the level up of overall retention. And so that was kind of how I was viewing that. I don't know if that answers that person's question, but and then the other question about how to implement training for organizations that feel like it's not relevant, especially in terms of cultural humility. And I would argue the ongoing conversation and continuing to bring this up in big and small ways. So there's like the rollout of large all organization trainings that many of us all have, and these required trainings and so forth, but also these smaller conversations. I also want to kind of reflect on what Dr. Mancini had said about kind of the makeup, the human resource makeup of an organization. So if we can emphasize hiring individuals of color in our workforce, not just in sort of frontline positions, but also in leadership, I think that elevates, that has the potential to elevate the conversation in a lot more sort of like globally. Yeah, so I believe that those are the components of the question. Thank you so much for that really good question.
Thank you so much, Dr. Peavy. I'll turn now to Dr. Mancini. Several questions about the work that you've done, and specifically, what challenges did you face working with smaller organizations, maybe those that didn't have as many resources? How did you address those barriers and challenges? And then finally, what are some resources that you can offer for organizations that are interested in doing the work that you did?
Thank you so much. If I can add a little bit to the last answer, the importance of having people of color in leadership is not only for the optics, it's not only for the visual, the importance of seeing people in positions of leadership, but it's because of what they bring to the table when decisions are being made about policy changes, about scheduling, about programs and services that are being developed. Individuals that will be bringing in the knowledge and the expertise from their culture, which are sorely missed in organizations that don't have that benefit. Some of the challenges for smaller organizations include part of the same issue. When you have fewer people around the table, there is an absence of the ideas or the challenges that individuals that you're serving may be facing, and it tends to be centralized over the same issue. And when some of these organizations literally had 6 people, well, it's very difficult in some organizations that are homogeneous and there is lack of diversity, of lack of linguistic challenges. Maybe they are doing exactly what they're supposed to be doing to serve the communities that they need to be serving. So it's not necessarily that they have to go out and reinvent something that doesn't exist in their community, but I think the needs assessment is the biggest part that these communities have to go through, which is how we start this process that they're going through, is taking that look as to where they are, not only in demographic makeup of the organization, at governance, leadership, and frontline staff, but also where their policies are, where their hiring practices, where their program development, where their schedules. How do those decisions get made, and do they take into account the needs of individuals that are different from where they are? The other challenge is that when we do this type of work, we like to interview not only what we call internal customers of the organization, which is your directors and your administrative staff, and the individuals you serve, but also external customers of the organization, which are organizations that make referrals to you, or organizations that you refer to for other complementary services. And those are limited when you have a very small organization, so you don't get to see how other people see you. So those would be the 2 biggest challenges that I faced. And I think you asked me about resources. Well, this is one of the greatest things about the Office of Minority Health. The websites that were offered at the beginning have a lot of information that is already been developed. There are roadmaps and there are lots of tools that can be easily downloaded to be studied for an organization to begin to take a look at some of these items. And then if you do need guidance, there are people that can help an organization be guided through this. But you can begin to do this yourself right after this webinar. You can start looking at, okay, where is my organization in this? What is it that I need to start doing? There are tools through the Office of Minority Health that you can start looking at.
Thank you, Dr. Mancini, and thanks for that additional plug to our resources. So I'm going to pivot because we've got several questions specifically about MAT, or medication-assisted treatment. So let me try to put a few of these questions together to pose to all the panelists. So I'll start specifically by asking perhaps Dr. Peavy to just do a really quick explainer for folks that might not be familiar with what medication-assisted treatment is, just to share with us what those 3 medications are and what that means. And then the question for the rest of the panel is, there's a lot of fear and mistrust in our communities when it comes to understanding and what medication-assisted treatment is, and trusting providers that this is a type of treatment that would be helpful to them. And there's also stigma, both in the patient community and in the provider community, about the provision of MAT, and this idea around how can you really be in recovery if you are still relying on medications to treat your substance use disorder. So how does one address those fear, mistrust, and stigma issues? And then finally, given those issues, what are some culturally appropriate strategies for engaging patients of color in treatment?
Sure. I'll just start by saying the 3 efficacious medications that I referred to in my 5-minute presentation are methadone, buprenorphine, and naltrexone. So, and there's, mountains of evidence that indicate that, taking these particular medications in a supervised way, in a treatment or healthcare setting, has good outcomes. And by good outcomes, I mean reduction or cessation of opioid use, but also some other good outcomes tend to be attached, like living. People are more likely to not die from a drug poisoning if they're engaged in medication of treatment for opioid use disorder than if they're not in treatment, for example. That said, patients and clients always have the choice about whether or not they engage in medication treatment or other types of treatment or no treatment. That's always up to the individual. And also people should know that these are the medications that are really the first line of treatment for opioid use disorder because they work so well. So, medications like, so anyway, I could talk more about that. But the issue of stigma, both among, patients in medication treatment as well as family members, healthcare providers, the issue of stigma is real. So I mentioned that I have a 20-year history in opioid treatment, and what I have seen over 20 years is that people have been more and more accepting of medication treatment. So my sense is that part of this acceptance is a little bit of education whereby people understand that these are medications that can save people's lives, help them change in very positive ways. And so part of all of our jobs may be to continue to educate, destigmatize, and so forth. So I have a lot more thoughts, but I'll let the other panelists weigh in. Thanks so much.
This is Celena here.
I can chime in if it's appropriate. Go ahead.
Okay, this is Celena here. So some of the things that we've noticed in working with some of my colleagues here who really are doing some great work and striving a lot of great efforts here within our tribal communities in the Pacific Northwest. One of the things that we noticed too is that one thing has been pretty helpful is you really taking a step back and looking at the narrative. Like I mentioned in my presentation regarding some of the things of looking at the trickster, and sometimes some of these methods and ways of Western medicine doesn't really necessarily fit with some of the language. And one of those areas can also be changing the narrative and using instead of substance abuse and using that and changing it to substance misuse. This relieves judging the person and also treating a person, not really shunning them. This definitely eliminates degrading and again, just putting more, a lot of tension and a lot of just hearing out on those individuals. Also, another thing is creating safe spaces, and I know there's another area that's been talked about. Some of the things I think in terms of meeting these individuals at their spaces and in terms of culture appropriateness is going into these tribal communities, and some of those little things can be even Narcan kits that we have been mailing to our 43 tribes here within our region, and just being able to have those available at the capacity. And I know, it's really related to MAT, but also it's definitely a step forward too, as we still, in a way, have quite a ways to go, and being able to address this stigma and being able to help those in recovery still.
I would add a couple of things that we've noticed in Hispanic Latino communities that we're trying to address is the absence and shortage of Hispanic Latino prescribers of medication-assisted treatment, which is being reported is a contributing factor to people accessing that treatment modality. And there's also the discussion about how long will people be on it. So there seems to be some individuals that believe it's short term, and now there seems to be some individuals that believe it may be longer. And I think that that's also causing some instability in Hispanic Latino communities about taking on a medication that they may not know how long they will be using it. But the biggest barrier that we've seen is the access barrier, is the cultural and linguistic access for opioid use disorder providers in attracting Hispanic Latino clients to access their treatment services.
Great. Thank you everyone for your response to that question. So next, around continuing to build competency in this area. So the first step is generally to take some sort of training or introduce training to the organization around cultural awareness, cultural humility, implicit bias. What's the next step for providers and for organizations? How does a provider take that knowledge and take it one step further to integrate cultural and linguistic competency within their practice? How does an organization integrate these principles within their systems?
I can start that one. I did show the 6 areas for action in one of my slides, which I think it's a perfect roadmap that organizations can begin to look at. The key is you need the buy-in from leadership, and it's a humbling experience, because in some of these organizations that I'm working with, 100% of the leadership is, in this instance, is white. And about 70 to 80% of their individuals being served in the organization are not. So it's a humbling experience for leadership and governance to be able to say, okay, we need to make some changes, which means there's going to be changes in governance, in leadership, in their directors, in their clinicians, but it needs to start there. But I think if you follow the implementation framework for the CLAS standards, it's a really simple process, but it's a long-term commitment that is going to require everyone's participation, and it's going to require taking a deeper look into the organization for them to make the changes at every level, from human resources to program development to hiring practices to scheduling and all of the other components of that organization. It begins with an internal needs assessment. I would always recommend perform an organizational, cultural, and linguistic competence assessment. You need to know what your foundation is. You need to know what your baseline is in order for you to be able to determine what your first step is going to be.
Thank you, Dr. Mancini. And final question for today, and this has to do with engaging non-treatment partners, so churches, other community organizations, working with the justice system. How can these partnerships be leveraged to either expand upon where there may be a lack of workforce diversity within a treatment organization, or to address other needs beyond treatment itself that an individual might have, or to address needs of specific populations?
Well, in my experience, two of the agencies that you mentioned, both faith communities and justice agencies, were very receptive. We had a multilingual, multicultural organization, and both of those were very welcoming to the opening of this organization, because they were desperate for resources, especially for linguistic access. So having clinicians that speak other languages continues to be a tremendous challenge in this country. But whenever we approached those organizations to let them know services, they were very receptive to doing that. At the same time, especially faith communities were always very receptive to any type of information, education, for whatever event that they would have. They were receptive about learning from the addiction or any other program that was being developed, especially if it was for Hispanic Latino communities and that was part of their congregation. They were very welcoming to that.
Thanks, Dr. Mancini, for sharing your experience on that. So sadly, we've come to the end of our hour together. I just want to thank our panelists again and to thank all of our webinar participants for joining us today. We hope that you'll find this information useful in the work that you do. Next slide, please. And for questions that we didn't get a chance to respond to today, we'll do our very best to provide response via email to you following the webinar. I invite you to please take a few minutes to complete our evaluation survey, which should pop up on your screen once you exit, but if not, you should receive the survey as well as a link to the webinar recording and instructions for receiving CHES or CMEs within 24 hours. Please also connect with us at the Office of Minority Health by subscribing to our newsletter and following us on social media. And you can visit us on the web at minorityhealth.hhs.gov. Next slide, please. And please also join our new learning community. We are so excited to engage with you in further discussion. So thanks again, everyone, and have a great day.